Hello everyone, my name is Yaser. I'm a postdoctoral researcher working with Professor Dale Bailey at Royal North Shore Hospital, and I am also a physicist at the School of Physics, the University of Sydney. Today my talk will be on an update of radiobiology for radionuclides. After a brief introduction, I will go over some of the radiation characteristics of radionuclides that are commonly used in radionuclide therapy, and then we will go through the radiobiology in radionuclide therapy and the conclusion. Metastasis is the leading cause of death from all cancer types, and for many patients, by the time the primary cancer is detected, it's already metastasized. This is further compounded by very limited and largely ineffective treatment strategies, resulting in poor prognosis across all cancer types. Therefore, the primary aim in radionuclide therapy is to treat the metastasis using radiolabeled molecules. As you can see in this clinical study, for example, the radiolabeled PSMA molecule with bismuth 213, which is an alpha emitter, was used to treat a patient with metastatic castration-resistant prostate cancer. So the role of radiobiology is to identify mechanisms and processes that underlie the response of tumors and normal tissue to radiation, which helps to explain observed phenomena such as cell repair, mechanism of DNA damage, and abscopal effect. Radiation therapy is classified in two classes, EBRT and RNT, external beam radiotherapy and radionuclide therapy. In EBRT, we mainly target the primary tumor, while in RNT, as I mentioned, we try to target the metastasis. RNT has mainly two modalities, targeted radionuclide therapy and selective internal radionuclide therapy. We use radionuclide that emit alpha beta particles, both positron and electron, Auger electron, and gamma radiation. And the type of radionuclide we use in RNT depends on the target. For example, for a large lesion, we need long-range particles such as energetic beta particles to have a sufficient dose coverage. And for a small lesion, we obviously use short-range particles such as alpha and Auger particles to localize the dose and minimize the radiation to surrounding tissue. In this schematic diagram, I would like to demonstrate the different decay processes and consequent emitted radiations with their DNA damage mechanisms. As you can see in alpha decay, because the alpha particles are heavy and they have 2 plus charge, they have high chance of inducing a repairable double-strand DNA break. Whereas in the case of beta minus emission, the beta particles are much lighter with one negative charge, and they can most probably induce a single repairable strand break. Also, for the emission of indirectly ionizing gamma radiation, the damage to the DNA mainly relies on the production of free radicals from the interaction of the emitted gamma with the water molecule surrounding the DNA. For nuclides that are decaying via electron capture process, they could result in higher T nanometer range Auger electron, and therefore they could also potentially cause a repairable double-strand DNA break if they are in the vicinity of the DNA molecule. The recoil effect of the daughter nuclide is another post-decay process that could also induce DNA damage. The recoil daughter nuclide can have kinetic energy with high residual charge, and if they interact with the DNA, they can cause a significant damage, and that's known as the Coulomb explosion. Now let's talk about how we deliver these therapeutic radionuclides into the metastasis. In targeted radionuclide therapy or peptide receptor radionuclide therapy, once the radiolabeled molecule is injected into the patient, the radiolabeled molecule finds its way to the tumor through the bloodstream and binds to the tumor-specific receptor according to a lock and key principle. Radiopharmaceuticals contain a targeting molecule such as peptide or antibody and a medical radioisotope conjugated by a chelating agent. The targeting molecule binds to a tumor-specific receptor according to the lock and key principle. In most cases, the targeting molecule can be used for both diagnosis and therapy, only the radioisotope has to be changed. This opens up the way for the application of theranostics in the field of precision oncology. Here is a list of beta minus particle with short range for targeted radionuclide therapy, and lutetium and copper are the most commonly used isotopes for the targeted radionuclide therapy. And also here's some of the long-range beta minus particle emitting radionuclides for targeted radionuclide therapy, and as you can see, P32 and Y90 are the commonly used isotopes in targeted radionuclide therapy. Also for alpha particle therapy, bismuth 213 and actinium 225 have shown promising results for treating metastases, and I will give some clinical example later in this talk. Here's also a list of type of carrier and targeting molecule that are used commonly in TRNT. In principle, the carrier molecules for targeted therapy needs to meet the following criteria. Firstly, the carrier molecule must possess high affinity and specificity for the target. Secondly, the carrier molecule should not be toxic or immunogenic, with preferable LD50 value of greater than 1.5 gram per kilogram of body weight. And thirdly, the carrier molecule has no resistance to self-radiolysis and well preserved both under storage conditions and upon contact with biological liquids. Also, the choice of an optimal antigen exposed on the membrane of tumor cells is crucial for therapy and diagnostics, and an ideal TRNT antigen must meet the following criteria. First of all, even expression and distribution over the entire cell surface of malignant tumors. Secondly, low or negligible expression in normal cells to minimize the side effect. And thirdly, detainment in the cancer site with no leakage to the blood flow. Okay, what is the role of radiobiology in TRNT? In radiobiology, as I mentioned, we use the cell culture experiments to derive the radiobiological parameters that can be used to improve and personalize the treatment strategies and protocols in RNT. So that for the treatment, we minimize the normal tissue complication probability, the NTCP, and we can increase the tumor control probability, the TCP. This yellow region is called the therapeutic window in radiation therapy, and in TRNT we aim to maximize this, expand this window by delivering the radiation dose very locally and minimizing the radiation exposure to the healthy tissues. So with this we can achieve a high TCP with less constraint on the NTCP. Although a single cell has many sensitive organelles, the cell nucleus is the main radiation target in radiation biology because it contains the DNA molecules. The response to the radiation, DNA damage and repair mechanisms, and radiosensitivity is highly dependent on the cell cycle profile. It is known by in vitro cell survival experiment that the cells are most sensitive to radiation during the mitotic and the G2 phases and are most radioresistant during the S phase. So for example, a cancer cell line that has a long S phase, it becomes relatively more radioresistant. So therefore, the cell cycle of a particular cell line becomes an important biological factor for the cell radiosensitivity. It is also shown by in vitro cell survival experiment that the cancer cell radiosensitivity also depends on the LET of the radiation. In this example that you see here, it shows the DNA double-strand break induced by a high and low LET radiation in human cell nucleus that is visualized using the gamma H2AX foci, and it's shown as the white dot, as you can see. In the figure A, as you can see, the cells are irradiated by a cesium-137 gamma source, which is indirectly ionizing radiation. And in this figure, the cell was irradiated with high LET nitrogen ion with LET of approximately 160 eV per nanometer to deliver a gray. And you can see the amount of double-strand DNA break that was produced using the high LET particle is much larger than what we get from a gamma source. And as you can see, with the increase of LET, the cell survival fraction decreases significantly at lower doses, which suggest they're more sensitive to higher LET radiation. Here in this video, you can see the alpha and beta particle track in a cloud chamber emitted from an americium source. These tracks are caused by ionization of the gas molecules along their tracks. So as you can see, for the beta particle, we see a thin and long track, and this is because of the low LET of the particle. And they have a mean separation between energy deposition events that is much larger than 2 nanometer, and the typical range in tissue is about 250 micrometer up to 9 millimeter. However, for the alpha particle, we saw a thick and short track with mean separation between energy deposition events that is much smaller than 2 nanometer. And this particle have a typical range of in tissue of 40 to 100 micrometer. And obviously, we could not see the gamma radiation or the gamma track because they are indirectly ionizing radiation. Another physical factor that can impact the radiosensitivity is the dose rate. As you can see in this dose rate effect spectrum, in RNT, the dose rate effect known to be very large, and that is due to the relatively low dose rate emission from the radionuclides that are used in RNT. Also, as you can see in this figure, I'm showing the theoretical survival fraction for acute EBRT and a few radionuclides with different half-life and therefore different dose rate to deliver a range of doses to 1 million cells. As you can see, the survival fraction for acute EBRT at any particular dose, delivered doses, is always higher compared to other radionuclides. And when we compare the survival fractions for these radionuclides, gallium-68 shows the most significant cell kill. And that's obviously due to the shorter half-life, therefore higher dose rate, and emission of positron. The emitted positrons from gallium-68 has a higher LET compared to beta minus or electron emission from the other isotopes, and we will talk about these LET differences and how that impacts the radiobiology in more details later in this talk. As I mentioned, for low LET particles or indirectly ionizing radiation, since the mean separation between energy deposition event is less than 2 nanometer, which is larger than the DNA helix diameter, if they traverse the DNA molecule, they most probably cause a single strand break or sublethal damage, which is repairable. So to cause a lethal double strand DNA break, 2 SSB or single strand breaks are required to happen within a time period which is shorter than the DNA repair half-life. However, as you can see for alpha or high LET particle, due to the mean separation energy deposition event being shorter than 2 nanometer, which is now comparable to the DNA helix diameter, if they traverse the DNA molecule, they can most probably cause an irreparable double-strand DNA break. The non-homologous end joining is a pathway that repairs double-strand breaks in DNA. This repair pathway referred to as non-homologous because the break ends are directly joined without the need of a homologous template, in contrast to homologous recombination repair pathway, which requires a homologous sequence to guide the repair. The non-homologous end-joining repair pathway is full of error, and therefore it can cause the cell death, which is known as mitotic catastrophe, and this is a common cell death from ionizing radiation. The repair pathway is known to be activated when the DNA broken sides are very close in space and time. Therefore, for low LET particle, the two SSBs need to happen close in space and time, which means before the DNA repair happens, and also the broken sides are close enough so that promotes the non-homologous end joining to cause a lethal damage and eventually the cell death. In radiation biology, the G factor is used to account for the kinetic of DSP creation, repair, and misrepair, and derive a true fraction of survival cells in an irradiated cell population. The G factor is 1 for a very high dose rate therapy, such as acute EBRT, but is much less than 1 for low dose treatment, which can be RNT. So the G factor can be simplified for RNT by considering the treatment time to go to infinity. And that will make the G factor only a function of the radionuclide and DNA repair half-life. So the G infinity factor here in this plot was calculated and plotted for a few commonly used isotope in RNT and also for emission tomography for comparison. As you can see, the shorter the half-life of the isotope, the larger the G factor. This means the isotope with shorter half-life will be more effective in creating a lethal double strand break from two single SSB events, because the damage rate is well competed or is competing more efficiently with DNA repair half-life. Here is an in vitro example demonstrating the effect of the dose rate on Y90 therapy. In this figure A and B, where I have plotted the cell survival fraction as a function of delivered dose for acute EBRT versus high dose rate Y90 and low dose rate Y90. As you can see, the low dose rate Y90 treatment or doses resulted in almost no cell kill, which is due to the dose rate effect and the small G factor of Y90, which is about 0.023. As I mentioned, for low LET and indirectly ionizing radiation, the dose rate effect can significantly impact the RNT treatment. Since in RNT, the dose rate decays more exponentially in the case of selective internal radionuclide therapy, no biological washout, and bioexponentially in the case of systemic or targeted radionuclide therapy with some biological washout, the dose rate at which the cancer cell receiving the doses is also decreases exponentially. Therefore, at some point, the dose rate would not be able to compete with the DNA damage, and therefore, although the physical dose might be delivered, but it will not be effective biologically, and hence it will be wasted. The critical time and dose rate are the radiobiological parameters that quantifies this dose rate effect as a function of the treatment time. As you can see here in this example, we found the most radioresistant cell line, HT29, colorectal cancer cell lines. It reaches the critical dose rate at much shorter time. Therefore, to achieve a greater cell kill for these cell lines, we need to irradiate the cells with an initial dose rate that always stays above the critical dose rate, which is 0.3 gray per hour for the whole durations of the treatment. The abscopal effect is another interesting radiobiological phenomena that is related to the dose rate effect. The abscopal effect of radiotherapy describes a rarely observed phenomenon in which one or more metastases located out of the radiation field regress at some point in time after radiotherapy. In this clinical example, an 80-year-old male patient with squamous cell carcinoma with bilobar hepatic metastasis underwent targeted Y90 radioembolization of the right hepatic lobe lesion. Subsequently, there was complete regression of the non-targeted left hepatic lobe lesion. The current hypothesis explains the abscorbal effect in 6-step post-irradiation. Step number 1, Y90 delivers radiation to the targeted tumor cells, resulting in immunogenic cell death. And in step number 2, tumor cell releases chemokines, cytokines, danger signals, as well as tumor-associated antigens. And in step 3, circulating dendritic cells, DCS, take up the tumor-associated antigens and travel to tumor-draining lymph nodes. And in step number 4, the DCS presents the TAS to naive CD4 T cells and CD8 plus T cells within the draining lymph nodes. Engagement of the T cell receptors on T cells with peptide complexes on the DCS results in the activation of the naive T immune cells. And in step number 5, the activated CD4 plus and CD8 plus T cells undergo clonal expansion and differentiate into effector CD4 T cells and cytotoxic T cells, respectively. And finally, in step 6, the effector CD4 plus T cells and CTLS migrate to treated and distant non-treated tumor sites and initiate tumor cell death. Recent studies have demonstrated that either an acute dose delivered at high dose rate or continuous and low dose rate with longer treatment time can potentially trigger the abscorbal effect. As we mentioned earlier in this talk, high-LET particle therapy is not relying on the dose rate effect because most of the induced radiation damage are direct repairable double-strand breaks. Bismuth-213 is a promising therapeutic isotope because it's an alpha emitter with high dose rate beta emission. Here is the decay path of bismuth-213, which primarily decays into polonium via beta decay, that is 97.8%, and via alpha decay to thallium, which is about 2.14%, with decay of these two daughter nuclei being 100% via alpha and beta emission, respectively. This is the first in-human treatment concept with bismuth-213 PSMA in a patient with metastatic castration-resistant prostate cancer that was progressive under conventional therapy. The patient was treated with 2 cycles of bismuth-213 PSMA with cumulative activity of 592 MBq and restaging with gallium-68 PSMA after 11 months showed a remarkable molecular imaging response. This patient also demonstrated a biochemical response, which is decrease in PSA level from 237 microgram per liter to 43 microgram per liter. The effectiveness of the targeted bismuth-213 is most probably due to the high LET of alpha particle and high G factor of the Here is another clinical example where we can see how different radiobiological parameters of beta and alpha particle results in different treatment outcome. As you can see in figure A, which shows the gallium-68 PSMA scan of a patient with castration-resistant prostate cancer with initial tumor burden. And then in figure B, you can see the disease progression despite of 2 cycles of beta miners emitting lutetium-177. And then in figures C and D, you can see an impressive decrease in tumor burden after 2 cycles of alpha-emitting actinium-225 PSMA with significant biological response with PSA level going down to less than 0.1 nanogram per milliliter. In addition to the LET and dose rate effect of the beta and alpha radiation, the source to target geometry also plays an important role in achieving a more effective biological dose response. This is the micrograph of micrometastatic cluster from ovarian cancer on a mouse model. As you can see, the alpha particles in red arrows can deliver much more localized dose in comparison to the beta particles, so therefore they can be more effective biologically with lower NTCP. Finally, I would like to talk about our recent work on the radiobiology of antimatter or positron therapy. Positron emitter isotopes are mainly used for PET imaging in nuclear medicine. Despite the superior radiation characteristic of positron in comparison to beta minus or electron particles, they have not been considered as a therapeutic isotopes. However, as you can see, the LED of positron are higher than electron due to their ionization mechanism during the thermalization and annihilation processes, and therefore they can be much more effective. As you can see here in this schematic diagram, a positron loses its kinetic energy in discrete quantities in tissue, which is approximately about 100 eV, producing brabbles of excited and ionized molecules. They create electron or ion pairs inside a spherical nanovolume along their track, which is called the positron spur, and the blob, which is the buildup of the spurs towards the end of his track during the post-thermalization process, with further annihilation ionization when they come to rest after the positronium formation. Furthermore, most of the positron emitter isotopes have shorter half-life and therefore higher G factor compared to beta minus emitter isotopes. And in our previous in vitro study, we have shown that 20 gray of fluorine-18, which emits almost 100% positron, can result in 90% cell kill. And comparing this with our Y90 cell survival study, we have shown that the RBE, or the relative biological effectiveness of fluorine-18, is almost 4 times higher than the beta minus emitter Y90 isotopes. In conclusion, dose rate, LET, and immune response are the key radiobiological parameter affecting the RNT. And for the low LET RNT, higher or constant dose rate can help with achieving a more effective treatment with obtaining immunologically effective dose, and the critical dose rate and time need to be considered for RNT treatment planning to enhance the biological